Okay, now moving on to mitral disease,
Bueno, ahora
which Bernardo
avanzamos
told me
con la
just to show a
enfermedad
bunch of cool
mitral.
pictures.
Bernardo
That's
me
mostly
pidió
what
que
this
solo
is going to
mostrara un
be.
montón de fotos chéveres y ya.
But hopefully you enjoy it. Again, I didn't
Ojalá
gain
les
any
guste la presentación,
financial
las
disclosures
fotos.
in the last
De
half an
nuevo,
hour.
no tengo ningún
I'm just going
punto
to
para
go
declarar en la
through. So in
esta
terms of
última.
new therapies for
Bueno,
mitral
entonces en
disease,
términos de
I would say
nuevas
there's not a
terapias para la
lot that's
enfermedad
come
mitral,
along the
yo diría que
pipeline
realmente no hay
for
mucho
mitral
que haya
stenosis, and it's
que
not a
contar para
problem
la
we see
estenosis
nearly as
mitral.
often in the United
Realmente no es
States.
un problema
That's
que veamos
probably
con mucha
why there's
frecuencia en
not
los
as much
Estados
work in
Unidos
that
y
space.
probablemente es por
So
eso
this
que
is going to
realmente no hay
be
tanto
procedures
trabajo ahí.
looking at
Estos eran procedimientos que se
mitral
enfocan sobre todo en la
regurgitation and
regurgitación
how it can be
mitral
treated
y
less
cómo puede
invasively.
tratarse de una forma
So I
menos
think
invasiva.
you're here at your institution.
Ahora,
I think you're familiar with MitraClip, and Andrea sort of
entiendo
alluded
que
to
ya
it
conocen
already.
bien MitraClip,
But the
Andrea ya lo
idea is
mencionó
that
algunas veces, pero
it's a
la
device that
idea
mimics
es
an
que es
alveoli
un
stitch repair, which
dispositivo
was a prior
que
open
simula
surgical technique that is still used
una
occasionally in the United States,
técnica de
but
Alfieri,
not as
¿sí?
commonly.
Todavía
At
se
the
puede
end, you have
hacer
a
en los Estados
double
Unidos, sí, pero no es muy común.
orifice
Y pues tenemos
mitral
un
inlet,
doble orificio
but
de la
hopefully
válvula mitral,
resolution of the
pero ojalá con
regurgitation, and it's
una
a percutaneous
resolución de la
deployment.
regurgitación.
And it's intended for patients who are at high surgical risk. So if you're
Está
able to have
dirigida a pacientes
surgery, we
que
generally
tienen un
feel
alto
that
riesgo quirúrgico.
surgical mitral valve
Entonces,
repair is in your best interest
si es que uno necesita
because
cirugía y
in
siente
the
que
right
la
hands, it can be
preparación
very
mitral es
durable and
mejor,
successful with
porque
relatively
pues
low
bien
morbidity and
hecha,
mortality.
se puede
This
tener
is for
mucho
patients
éxito
who
con una
don't
movilidad y
otherwise
mortalidad bastante baja.
qualify for surgery.
De
So
nuevo, esto es para
looking at
pacientes
the
que no
US
califican para
valve
cirugía.
guidelines from
Entonces,
2020, once again,
fijémonos en las guías de válvulas de los Estados Unidos.
they're stratified by
De
primary
nuevo,
versus
vemos que
secondary
están
mitral
estratificados por
regurgitation. So in patients
regurgitación
who
mitral primaria y secundaria.
truly
Entonces, en
have
pacientes que verdaderamente tienen
severe regurgitation,
una
they have
regurgitación
symptoms
severa,
regardless of LV function,
pues hay síntomas a
but
pesar de
they're
la
at
función
high
del
or
ventrículo
prohibitive
izquierdo,
surgical risk,
pero que
and they
tienen un
have
riesgo prohibitivo
anatomy
de
that's
cirugía y que tienen una anatomía
favorable
que
to MitraClip,
favorece
and
el clip
they are
mitral,
expected to live at least 1 year, then it's a 2A recommendation
pues en ese caso es
to
una
go
recomendación
ahead
de
with transcatheter edge-to-edge mitral valve
de
repair, which currently the
de ambos
only
sentidos para
or the
utilizar un
main
catéter
device on the market is
transmitral,
the
que es
MitraClip.
posiblemente el único dispositivo
And then
que como
similarly for
alternativa
secondary
al
mitral
mitral.
regurgitation,
Y para
once they've been
regurgitación mitral
optimized on
secundaria, una
guideline-directed
vez que se haya
medical therapy,
optimizada en la terapia médica,
if they have severe symptomatic
pues si
mitral
tienen
regurgitation with a low
regurgitación
EF
mitral
and
sintomática
persistent symptoms
con una
despite being
baja
on
fracción de
optimal medical
eyección y síntomas
therapy
persistentes a
and
pesar del tratamiento médico,
mitral anatomy that's favorable to clip,
una
and
anatomía
they
mitral que
don't
sea
meet any of
favorable,
these exclusion criteria
y
from
si además no tienen criterios
MITRA-FR
de exclusión
and COAPT, then it's also a 2A recommendation
coacto
for
mitral
secondary severe
FR,
MR to
entonces
attempt
también
a mitral clip.
está bien indicado.
So I'm just going to take us through some videos here. This is a
Yo quiero
patient
mostrarles
we
algunos
did
videos.
several
Este fue
months
un
ago.
paciente que vimos hace unos cuantos
Who you can
meses.
see here has he
Y
has
veremos
reduced
aquí
EF,
que
and he has
tiene
a
una fracción
restricted
de eyección
posterior
reducida,
leaflet due to wall
tiene
motion abnormalities in
una
the
valva
lateral wall, and a sort
retraída
of
debido a
anterior
algunas
leaflet
anormalidades de la pared
pseudoprolapse or
con
override.
un pseudoprolapso además.
Here's an image with color, so very
Aquí
eccentric
tenemos una
jet.
imagen a color. Vemos que hay un chorro muy excéntrico.
Here's this is at 90 degrees.
Aquí tenemos
So again, restricted posterior leaflet,
la restricción posterior,
and anterior override
la válvula,
with
sobreposición
color,
anterior,
and then this is the long
con color.
axis. So one of the main things we look for anatomy that's suitable for clip is we want the posterior leaflet length to be adequately long for us to get enough tissue in the clip, and then we don't want it to be the valve to be significantly calcified, so that wasn't the case for this patient. And then here's the color again with the posterior directed jet and a decent sized flow convergence radius even without adjusting the baseline. And here's the 3D image. So you can see here the anterior override from the posterior restriction, and then with color, the jet looks a lot more impressive than it did on 2D, a very wide posteriorly directed jet. So mitral clip is done through a transfemoral approach and then transfemoral venous approach, and then we go across the interventricular septum. And our goal, so this is approximately a bicable view at 110 degrees. So this is superior, inferior, and then on the right image, this is an X-plane, so this is the orthogonal image. This is posterior and anterior, and our goal is to get posterior as much as possible, as much as we safely can, in order to give us as much height above the mitral valve to maneuver once we get across into the left atrium. So T is crucial for this guidance, or crucial for this step, because they literally can't see the septum on fluoroscopy. So once we get in a good spot, they use radio frequency to pulse us across into the left atrium, and then we put a wire across and put a catheter across.
Una guía
This is
y un
our
catéter
dilator
para
to
atravesar.
get the
Tenemos
catheter.
nuestro dilatador para poder poner el
And
catéter.
then T is also crucial for
Y
guiding the catheter over
esto es
through the
crítico
left
para
atrium
guiar
and not
el catéter
hitting the
a
posterior
través del
wall and causing an
atrio
effusion.
izquierdo y no golpear la pared posterior,
And here,
generando una fusión.
this is the clip actually coming
Y
out of the
este es
device
el
a little
clip que
bit
de hecho
here out
está
of the guide.
saliendo.
So once we maneuver over the valve and we cross, we orient ourselves medial lateral as well as anterior posterior, and then we cross the valve once we think we're in a good position.
Cruzamos la válvula
This
una vez
again
que
is an
estamos en una buena
orthogonal,
posición.
an X-plane image. So this
De
is
nuevo,
approximately the
esta es una
bicameral
imagen,
view. On the left is
esta es
60
una
degrees,
aproximación
and on the right, this is the
a
long
60
axis
grados
or
y en la
grasping
derecha
view, as we say, so we
vemos
can
el
see
eje
both
largo,
leaflets as they
un
fall
grasping
on the
como se
arms
le
of the
suele llamar.
device. And then once we think we're in a good
Una
spot, we
vez
drop
que
the clip
consideramos que
arms,
estamos en buena
and you can
posición,
see
soltamos los brazos
these,
del clip y podremos ahí sí
vector
observar
density just above the clip arms, and it's kind of bouncing a little bit
la
on both sides. That's a good sign. It
cogenicidad que
means that we
está
have
justamente
leaflet
por encima del clip y está
trapped,
rebotando
and
un
it's
poco
just
en ambos
moving a
lados.
little
Eso es
bit
bueno.
as
Eso quiere decir que
through the cardiac
están
cycle.
bien agarradas las valvas y solamente
And
molesta
we
un
go
poco el
through
anticiclo
and we
cardíaco.
check our
Ahora
leaflet
revisamos
insertion.
nuestras inserciones de las
So we can
valvas.
see here at 30 degrees,
De
there's still
manera
a reasonable
que
jet
damos los
that's
30
sort of
grados. Todavía hay un
posterior
chorro
lateral of
razonable que
the
es
first clip.
posterolateral.
But
clip.
we thought that the clip was in a good spot, so we went ahead and
Pensamos
let
que el
it
clip estaba
go.
en una
But
buena
you can see
posición.
the 3D, so we have
Entonces
our
aquí podemos ver
tissue
el
bridge
clip.
here,
Tenemos nuestro puente de tejido,
which is
que es
has provided good leaflet stability at
nos
that
ha dado una buena
medial portion of the
estabilidad
valve, but there's
las
still
valvas en la
a
porción
fair
media de
amount
la
of
valva.
anterior override
Sin
on
embargo,
more
sí ha habido una
laterally,
sobreposición
and color
importante
shows us there's still a
de
fair
forma
amount of mitral
unilateral y
regurgitation.
los colores muestran que
So
todavía hay una
in that
regurgitación
context, we
considerable.
said, well, we're going to put a
En ese
second clip
contexto,
in, and we're going to go lateral
vamos a
to
tener
the
un
first
segundo
one.
clip y vamos hacia
So here
lateral.
we are in the bicom. I think this
Aquí
is already
estamos en el icono.
grasped.
Creo que esto ya está
And
bien
once
agarrado.
we go ahead and close
Y
the clip,
una
we
vez
can
que
see the
podamos cerrar el
regurgitation
clip,
has
veremos que la
decreased
regurgitación
significantly.
se ha reducido
And this is what it
significativamente.
looks like
Y así es como se ve
post. So it looks pretty much like that
en la
diagram I showed you
postfase.
before with the
Se parece
alveoli
mucho al
stitch, where we
diagrama que
have sort of in the
mostramos con
center, there's
punto de alfieri.
complete coaptation of the leaflets
Sí,
with no
vemos que hay
movement, and
una
then
captación
on either
completa de
side it's
las
sort of like the
valvas
owl
sin
eyes
movimiento.
opening and
Entonces se ve
allowing
efectivamente con los
inflow
ojos
during
de búho,
diastole.
¿sí? Que permiten el flujo de
And
la
then
diástole.
quite a dramatic difference in the regurgitation.
Y
So it's a
una
very
diferencia muy dramática en
satisfying
la
result for
regurgitación.
this patient.
Este es un resultado muy satisfactorio para este paciente.
Okay, so the next technique I want to talk about is
Entonces, la próxima
lampoon valve
técnica que
and
quiero mencionar
valve transcatheter
es
mitral valve
un
replacement. So
reemplazo de válvula mitral
for
transcatetera
patients who've had
de
prior
lampoon.
mitral valve repair with annuloplasty
Ahora,
ring in place,
aquellos que han tenido
it is
reparación de
possible
válvula
for us
mitral
to
anterior con
do
un
valve and
anillo
valve procedures with
ubicados, sí
sapien
podemos hacer
TAVR
procedimientos
valves,
válvulas
essentially, just
con
oriented the
válvulas
opposite
TAVR.
direction.
Es decir,
And
que
that
entra
can
por
allow
la
for
dirección opuesta y
either
eso puede permitir que
cure
haya
of stenosis or
ya
regurgitation
sea
that may have
estenosis
developed
o
in the years
regurgitación
since their
que se
repair.
han desarrollado
One of the
durante
problems,
los
though,
años.
is that with patients who
Uno de
have
los
very
problemas, sin
long
embargo, es que
anterior
con los pacientes
leaflets,
que tienen unas valvas
when you push
anteriores
it out
muy
of the
grandes,
way, when you
cuando se
inflate the
empuja
balloon
hacia un lado
to
y cuando
deploy
se
the
infla
valve,
el balón
the
para
anterior leaflet
entregar
can
la válvula,
cause
la valva
LVOT
anterior
obstruction.
puede
And so
generar
you sort of create a new problem
una
where it
obstrucción
wasn't
del
before.
ventrículo izquierdo.
So there's this technique that's been developed called the lampoon,
Entonces,
where
hay una técnica que se llama
we can take
el doble
we
lampoon.
cross the septum in the same way as for
Quiere decir
mitral
que se
clip.
cruza el septo, igual que con
Cross a
el
wire
mitral,
across the mitral
y se pone
valve
una guía a
and then into
través de
the
la válvula
aorta.
mitral y que
And then
luego entre
from
hacia la aorta.
the femoral artery, we
Y a partir de la
bring a
arteria
catheter up
femoral
through the
se puede
arch
tener un catéter hacia el
and
arco
snare the wire
y ahí
and then
atrapar
pull it out
la
of the
guía
body
y
through the
sacarla
groin, and then
por
put
ahí,
another catheter
por la
up.
ingle. Y poner otro
And so we
catéter
have two
en su
catheters,
lugar.
one
De
coming
manera que
from
tenemos dos
the
catéteres.
femoral artery, one
Una
coming
que
from the
viene
femoral
de la
vein and
arteria
crossing the
femoral y la
septum.
otra que viene
And
de la
then
vena femoral
we
y que cruza el
expose some
septo
wire
interatrial.
between the two
Exponemos
catheters
entonces algo de
and
guía
place
entre
it
los dos
carefully right
catéteres
along the
y lo
anterior mitral
ubicamos
leaflet,
adecuadamente
and then
por
pulse radio
sobre
frequency
la
through it
valva
to
anterior. Y luego se
sever
pone esa
the
frecuencia ahí
leaflet,
para
essentially,
cortar
lacerate
esa,
the leaflet
lacerar esta
from
valva
tip to base, and that
base hasta la
significantly
punta
lowers the
y
risk
no
of LVOT obstruction.
y reducir
So,
significativamente el
so this
riesgo de
is
obstrucción del
a patient we
ventrículo
did a
izquierdo.
few months ago.
Ahora, este es un
You can
paciente
see
que
there's an
hicimos
annuloplasty
que
ring in
trabajamos hace
place,
algunos
and the
tiempo,
posterior leaflet
tuvimos
has
un
a
anillo
flail segment,
colocado
which
y vemos
is
que hay un
the
segmento que
cause
está
for the
libre y
recurrent,
esa es la
very
causa
eccentric, anteriorly
de
directed
este
mitral regurgitation. This is a long axis view. Again, you can see a pretty long anterior leaflet. If we were just to push this out of the way, it would really cause some issues in the LVOT. But there's the posterior flail as well, with dramatic eccentric jet. And here's the 3D.
Aquí tenemos la imagen en
Here's that
3D.
posterior flail.
Veremos ese
And then with
maleteo
color,
posterior.
again, more dramatic than the 2D
color.
color.
De nuevo, es mucho más dramático que el color.
So,
2D. En la imagen 2D.
This technique requires us to do
an
intraatrial septostomy, because to get the sapien valve across, we have to have a very wide orifice. So this is just the T guidance of the septostomy with the balloon inflated. And then once we get the septostomy, we feed our wire across the septum, across the mitral valve, and you can see here it's in the ascending aorta as well. So then once it's snared and pulled out of the body, they feed the catheter up from both sides. So here we have the catheter coming from the atrium, catheter coming from the aorta, and it's hard to appreciate because it's thinner, but the wire is in the intervening space between the two. And so this is, again, where T is really crucial. So this is a multiplanar reformat image with 3D on the bottom right here, but we want to really make sure we're sort of right in the center of the anterior leaflet, and that our wire is the exposed part of the wire is actually centered over the mitral leaflet. Because if we're too high, and this catheter, for example, this is the aortic catheter, is too high, then we're not going to sever anything. And if it's too low and the wire is exposed over here, we could cause problems with the aortic valve. So then we went ahead and the bubbles are all from the radiofrequency pulse through the wire, and you can maybe appreciate in the 3D image here how the catheter moves from the center of the valve all the way to the anterior portion of the ring, and you can appreciate it certainly on this image that we sort of lacerated the leaflet at this point. So I put these side by side, so hopefully you can see. So here, this is the pre-image with the anterior leaflet intact, and now there's this sort of triangular space between the two portions that we've lacerated. And then, as you would expect, the mitral regurgitation becomes a lot worse very suddenly, so we have to act pretty quickly in order to put the valve in place and prevent hemodynamic instability. So then this is, we pull the wire, or we pull the catheter out, put our valve in, and then this is a balloon expandable sapien valve, so we expand that into place. And then this case in particular, so the valve looks good, but we had some paravalvular regurgitation from the through the stent, because the valve leaflets were a little higher than maybe was ideal. So we did some and here, as you can see on color, sort of on the anterolateral aspect of the valve, and we still have our wire across, so we have access to the ventricle. So we did a post dilation to try and better oppose the stent to the ring. And at the end, there was still some mild paravalvular regurgitation, but probably not something we were going to fix by further post dilating, because it's not on the outside of the stent, it's actually going through the stent because the leaflets are a little bit high. And then the post looks like this. And then with color, so intravalvular regurgitation is nothing, and we just have a very small paravalvular regurgitant orifice there. Okay, and then another technique that we've used at Yale is using the Intrepid valve, which is developed by Medtronic, transcatheter mitral valve replacement, that's only being done as a part of the Apollo trial. It's a self-expanding valve, and there's two different sizes for the outer stent, 42 and 48 millimeters, and then the inner valve is a 27 millimeter bioprosthetic. And this is just a picture of what it looks like. And they have two arms. There's a primary arm that's for patients who don't have significant MAC, and then the MAC arm is for patients who have a high burden of mitral annular calcification. And this is only for patients who have at least moderate to severe mitral regurgitation and are not a surgical candidate or a mitral clip candidate. So they have to meet both of those inclusion criteria, or both of those inclusion criteria, exclusion from other procedures. So Here's images from a patient we did a couple of years ago, and you can see sort of similar anatomy to the mitral clip that I showed you in terms of there's a posterior leaflet restriction with anterior leaflet override. You can see that the posterior leaflet is really hard to appreciate because it's so small and short. So that was the reason this patient was felt to be not a mitral clip candidate. There wasn't enough tissue for us to grasp. So, but similar story of anterior leaflet override with posteriorly directed regurgitation. Here now in the long axis view, sort of more of the same. And here's that anterior override with the posterior restriction on a 3D view. And regurgitation on color.
Y regurgitación a color.
So initially the Apollo trial was done via transapical approach, so they would do a thoracotomy. The surgeon would do a thoracotomy. They would approach the apex and then cannulate the apex. And you can see here, this is them poking through with the wire to get access to the left ventricle. I should say before I forget that the trial now is only transeptally done, but initially they were all done transapically. So and then they introduced the valve into the left ventricle,
hacia el ventrículo izquierdo,
cross into the left atrium,
se cruza hacia el atrio izquierdo,
and then slowly back down to start to deploy the valve. And again, it's self-explanatory, so they're just pulling the sheath back to let the valve open on its own.
Para dejar que la válvula se abra sola.
And then this is the valve mostly deployed.
Esta es la válvula ya casi totalmente desplegada.
And we do and then this is it fully deployed. So you can see this is there's the components of the outer stent here that interface with the annulus, and then the inner valve itself is what allows where the leaflets sit and allow for flow during diastole. And there's just very mild, trace to mild intravalvular regurgitation at the end of this. So as I sort of alluded to with the lampoon, though, in patients who have long anterior leaflets, there's this risk of LVOT obstruction. And this patient, I'm sorry, this is a 3D view of the valve.
Esta es una vista en 3D de la válvula ya desplegada que se ve bastante bien.
And here again with color, so just some trace intravalvular regurgitation. But you can see here on color that we do in fact have some LVOT obstruction, it appears, for this patient. She had a long anterior leaflet. So it ended up not being clinically significant. The patient did okay in the setting of this, but we found now at Yale that in the past couple of years we haven't had any patients who have screened positive for this study because they all are at too high of a risk for LVOT obstruction. So that's one of the sort of drawbacks of this system. I think, do I have a few more minutes?
Creo entonces que tenemos unos minutos más, sí, para mostrar. Bien.
I guess I'll just end there. Thank you to all the people on this slide.
Quiero ofrecer mis agradecimientos a las personas que están en este diapositivo.